Thank you very much. I'm going to talk about ALTK, hemi-automated lamellar keratoplasty, and sutureless hemi-automated lamellar keratoplasty. Thank you, ma'am, for inviting me to participate in this instruction course. Lamellar keratoplasty is a very useful technique, and with judicial case selection and proper planning, it can give very good results. I'll give you an overview and some illustrative case scenarios, and we'll take question and answers towards the end. So you have to have a kind of an algorithm to determine which patient you're going to operate in which, by which method. A ballpark figure or a general rule of thumb could be to look at the depth of the opacity. So superficial opacities of less than 100 microns, they do very well with phototherapeutic keratoplasty, keratectomy using a femtosecond laser, using an eczema laser. If it is a little deeper than that, about 100 to 200 microns, then one can consider what is called a superficial anterior lamellar keratoplasty. If it goes to the mid-stroma, then you can either do a fully automated lamellar therapeutic keratoplasty or what we call a hemi-automated. When we say hemi-automated, we dissect the donor with the Moria microkeratome, and the host we dissect manually. And if it goes to the posterior stroma, then one would do a DAL. So this is the concept of a customized component replacement therapy. So with a few examples in terms of case selection, investigation, surgery, and follow-up, I hope to be able to make this concept simplified for you. This is a case which was worked up by Dr. Pradeep and Dr. Chanchal, junior and senior resident working in our unit. There was a 20-year-old gentleman who complained of a painless diminution of vision, and he had bilateral symmetrical white opacities over the cornea involving the anterior stroma. And clinically, the diagnosis was a Bowman membrane dystrophy. Around the same time, we had a few weeks before this patient, we'd had another similar patient for whom we had tried PTK. In this particular patient, the depth of the opacities clinically as well as with the ASOCT were a little bit deep, about 92 microns, and we felt that just a simple PTK would not help. However, in such a patient, if you want, one can try a PTK first, and if that doesn't clear the opacities adequately, one can even proceed later to any of the surgical techniques. So this was a patient, both eyes Bowman's layer dystrophy. So clinically, this was either Rees-Buckler, Thiel-Benken, or Benke, or Grayson-Wilbran corneal dystrophy, and this is the differential diagnosis that we consider, and clinically we felt it was a Rees-Buckler variant. Now, the indication for surgery was that his vision was poor with only 1/60, and we had these options. As I explained to you, the opacity seemed a little deeper, so we didn't go for the PTK. The option was an anterior lamellar keratoplasty, and as has been beautifully explained by the speakers before me, a penetrating keratoplasty was not an option. So the involvement was about 100 microns. The plan was, even by reviewing the literature, generally when PTK has been used in dystrophies, the maximum ablation depth recommended is about 100 microns, and from a series that we had at our own center, we found that usually it was about 65 microns that we were able to restore adequate vision. So this was a little deeper than that. For lamellar keratoplasty, you have the option of doing a fully automated, where it is safe and effective for disease affecting the anterior to the mid-stroma. We have only a 200 micron microkeratome head, and that tends to cut a little bit deeper. We didn't want to disturb the patient's cornea that much, so therefore elected to go for what is called a hemi-automated lamellar keratoplasty, where there was a manual dissection of the host up to the level of the diseased cornea. So there's manual recipient bed lamellar dissection, automated donor preparation, so it combines the benefits of a smooth microkeratome lamellar dissection of the donor with the customized lenticule thickness of the host. And then with the rest of the cornea, one was also able to do a DSEC in this patient. This is an example of the patient who had the DSEC and the HALK post-operatively. The surgery was done by my colleague, Dr. Vanathi. Here is the microkeratome cutting of the tissue, where a 200 micron head was used, and the donor tissue was cut, the lenticule was confirmed, and then the host button was trephined. A partial thickness depth was dissected with the help of the Hesburgh-Barron trephine, and we also reconfirmed this by using a micrometer diamond blade to reconfirm the depth and dissect just up to that level. So this is, and generally it's easier to do the open technique. Ma'am is extremely experienced, so she is comfortable with the closed technique, but it can be a little difficult to do a closed technique. So if one is a beginner, open technique is much safer, and you just go to the depth. The other thing is, when you're dissecting such patients, there is a little haze created by the stroma, so you get confused whether you have really removed the whole opacity or not. And for this, we now have the Zeiss Lumera microscope, which will have an ASOCT inbuilt. So that is another tool which could be helpful in such cases. And this patient was then sutured, and the surgery went off very well. This is the patient post-operatively on the first day, and this is what it looks like. And the histopathological examination had confirmed a Rees-Buckler dystrophy. And this is the post-operative ASOCT of the patient. So the importance shows that one can do a combination of treatment, and as Srilata showed you, when you're using automated keratome, you have to make use of the nomogram to try and determine the exact diameter of the cut as well as the depth of the cut that you have. This is another example of a patient who was worked up by my senior resident, Dr. Anita. She had a post-refractive surgery, corneal opacity. She was 32-year-old, and she had LASIK for -6 diopter refractive error in both eyes 2.5 years ago. She had complained of a gradual painless progressive diminution of vision in the right eye 5 months after a blunt trauma to the right eye in a road traffic accident, and her unaided visual acuity was had been 6/6 both eyes after her LASIK surgery, but she presented with 1/60 vision in the right eye and 6/6 in the left. And slit lamp examination showed Descemet's folds with scarring, which was believed to be due to flap dehiscence at the time of accident. And she also had a small macular scar over the parafoveal region, suggestive of perhaps some macular edema or Berlin's edema at the time of the trauma. Clinically, we felt it was possibly the sequelae of a flap dislocation with macrostria, and that was a preoperative picture. So the management, the folds were long-standing, there was scarring, and we felt that just lifting the flap, repositioning was not an option or advisable. Superficial anterior lamellar keratoplasty was planned on ASOCT. The depth of scarring was 154 microns, and manual dissection was performed with a diamond knife set at about 160 microns. The interface was cleared thoroughly with washing to avoid any epithelial ingrowth. The donor cuts, if we would have been happy if we had a thinner blade, but we had a 200 micron head. You can control the depth of the cut a little bit. If you go faster with your microkeratome blade, you go a little deeper, and if you go a little slower, it can be superficial, but that is really a very approximate technique, so you can't really fine-tune it perfectly. And the donor tissue was trephined with 8 millimeter, and it was placed on the host bed. The patient had a vision of 6/18 at 4 weeks post-operative, and this patient was treated with MAM's technique of using the fibrin glue, so she had no sutures at all. And this is the final case. Amreen, a junior resident, and Priyanka, the senior resident, looked after the patient, 48-year-old female who had gradual onset painless progressive diminution of vision in both eyes for 10 years preceding presentation with no other significant history. She had a vision of 6/12 in the right and 6/60 in the left, and on refraction she had some astigmatism. Clinical examination, she had these superficial opacities in both the eyes, which were suggestive of a granular corneal dystrophy. Here you can see the opacities. The opacities in the right eye were more scattered and not involving the visual axis, whereas the ones in the left eye were a little larger and plaque-like and affecting the visual axis. So the diagnosis was a granular corneal dystrophy. Her tear function tests were normal, and she had good visual potential, and she had some astigmatism. The ASOCT confirmed that the depth of opacity, the cornea was a little bit thinner on the left side, 471 microns, and the depth of the opacity was estimated to be 172 microns. First option was refraction. She was refracted, her right eye improved, but the left eye was not adequate to suit her requirements, so we ran for surgery. Again, as I discussed before, PTK we didn't consider because the opacity was deeper than 100 microns, and particularly that central plaque-like opacity which we had to get rid of. So anterior lamellar keratoplasty, we had the option of manual and automated, and then whether with or without sutures. The advantages of sutureless anterior lamellar keratoplasty is obvious. However, we realized later that what we thought would be that it would lead to less astigmatism, that turned out to be not true, and I will discuss that later on. So one of the benefits we thought with sutureless would be less astigmatism, but that may not necessarily be true. So sutureless, microkeratome assisted, hemi-automated lamellar keratoplasty, and of course another option would have been a femtosecond laser assisted keratoplasty. So as I explained, there's a nomogram to predict the residual cornea should be 250 microns even with this kind of surgery, because once you enter that layer of the cornea, there is a loss of tensile strength and there is a weakening of the cornea. So here's a quick video of the patient, a patient's surgery. This is how the donor was prepared using a Moria microkeratome and a non-optical grade cornea with a larger rim. You need at least a 3 millimeter rim so that it is nicely covered and sealed by the artificial anterior chamber without a leak. It should be well centered, and under the microscope one would make sure that the tension is adequate, and then intraoperative pachymetry can be quite helpful, and then the tissue is cut. Basically the rest of the steps are very similar to the case I showed later. So in the interest of time, I will skip. And sutureless lamellar keratoplasty and scleral patch adhesions, fibrin glue is able to give a reasonably, in fact, a very good support. We haven't had any problem of dislocations, and so it should hold. It holds the lamellar cap well. The fluid pump should hold the cornea together, and it can provide an additional support to prevent against spontaneous or mechanical dislodgement of the flap, and it is followed by application of a bandage contact lens. The patient did well postoperatively except for the astigmatism. It might be because of a discrepancy between the donor cut and the host cut. So I feel maybe with femtosecond laser this astigmatism would be less. I do not think it is that much related to this to the glue as maybe to the discrepancy in the dissection of the donor and the host. And these are the ASOCT pictures and the postoperative picture of the patient. So take home message: it is effective for superficial corneal opacities, a swift visual rehabilitation, and no suture related complications. Thank you.
Thank you, Professor Radhika.